Good afternoon, everyone. I'm Dr. Vamsi Krishna, consultant neonatologist and pediatrician at KIMS Cuddles, Kondapur. As we know that we see so many babies who are having jaundice, and we are managing the babies quite well in all the parts of the world. Also, we are able to provide the phototherapy for these babies. With the result of this, we have seen so many decrease in the incidence of exchange transfusions. However, in some areas where the awareness is not yet clear, the babies are still having very high bilirubin that lead to a peculiar condition called as bilirubin induced neurological dysfunction, which have an immediate and long-term impact on the baby's neurological status. So today we'll discuss this topic in detail so that we can have a better idea in early identification and the management of the condition. The overview of my topic is, first we'll discuss what is bilirubin stuck in metabolism. We'll discuss about BIND and its definition. We'll discuss about the risk factors for it, then pathophysiology and neuropathology of BIND, various clinical aspects of bilirubin encephalopathy, and how we diagnose it and how we treat the condition. Normally, bilirubin is a product of the porphyrin ring of heme. So the majority of the heme comes from the breakdown of the RBCs. However, there is additional source of the heme that we'll show in the next slide. This bilirubin that has been formed from the heme exists in the plasma either as anions, which may be mono or dianions, or it can be in the form of bilirubin acid. The dianions can actively bind with the albumin. However, at a physiological species, pH, majority of the free bilirubin that is present in the body is around 82% is the diacid, 16% is the monoanion, and 2% is the dianion. The dianions bind with 2H plus ions and results in the formation of a diacid, which is the chief component that is present at the normal pH of the body. This diacid is very poorly soluble in aqueous solution, and it gets passively transported across the plasma membrane of cells. The concentration of the free bilirubin diacid when exceeds its limit of the aqueous solubility, it lead to the formation of a soluble oligomers and the metastable microaggregates. At very high concentrations, this diacid forms insoluble precipitates which actually cause injury to the membranes of the cells. So here we can see the bilirubin metabolism. So you can see 75% of the heme is formed from the catabolism of the RBCs in the reticular endothelial system. And 25% of heme is formed from other systems where ineffective erythropoiesis of the RBCs and other cells in the bone marrow can lead to the heme production. And also there are other heme proteins like your catalase, myoglobin, peroxidases, and cytochromes can lead to the production of the heme. From this heme, this enters the reticular endothelial system, where the enzyme heme oxidase, which convert this heme into the biliverdin, and then the biliverdin reductase will convert the bilirubin to the bilirubin. This bilirubin will bind with the serum albumin and is transported to the liver. In the liver, the bilirubin is separated from the albumin, and the liver will take this compound by specific organ anion transporters and bind with the ligandin and transfer it to the endoplasmic reticulum, where you have the UDP glucuronidase transferase enzyme, where it conjugates the bilirubin to form the bilirubin glucuronides, monodigluconides, and which get excreted into the intestine, and where the bacteria will act on it and finally excrete the fecal bilirubin and urobilirubin. If there is decrease in the intestinal movement and the prolonged intestinal transit, the beta-glucuronidase enzyme that is present in the brush border of the intestine will convert this conjugated bilirubin to the unconjugated bilirubin, which again get absorbed into the blood from the intestines and circulate to the liver. This is called as enterohepatic circulation. So in this way, the bilirubin is formed and get metabolized. The major cause of neonatal unconjugated hyperbilirubinemia are either because of increase in the production due to hemolytic disease, which may be immune mediated or non-immune mediated. The immune may have Rh and AB incompatibility. The non-immune mediated, we have red blood cell membrane defects like spirocytosis, hemoglobinopathies like thalassemias, or enzyme defects like G6PD or pyruvate kinase deficiencies. Or there may be increased production from excessive amount of the blood accumulated in the extravascular spaces like cephalohematoma or intra-abdominal bleeding. Or there could be polycythemia where the more amount of RBCs are there. In the case of sepsis with multiple mechanisms, and there may be increase in enterohepatic circulation because of breast milk feeding, or maybe intestinal atresia where you have an increase in enterohepatic circulation. Or in the case of a prematurity, there will be multiple factors will be there, and there will be decreased conjugation that happen in the case of premature because of the immature enzymes and because of genetic defects in the UDP glucuronidase transferase enzymes like Crigler-Najjar syndrome 1 and 2 and Gilbert syndromes. And in case of a congenital hypothyroidism, these are the cases usually have the babies have a significant amount of unconjugated hyperbilirubinemia. So the BIND is the first description of bilirubin encephalopathies by the Schmoll in 1903. So usually BIND occurs when the total serum or the plasma bilirubin levels exceeds and the infant's neuroprotective defenses. To a certain extent, our body and try to prevent the effect of the bilirubin to our brain. When this level is exceeded beyond the protective defenses, this bilirubin can lead to the encephalopathy. The most commonly injured areas are the basal ganglion, the central and the periphery, auditory, and the visual pathways. On average, 1.4 to 2.7 per 1 lakh live births of 35 more than 35 weeks of gestation are having affection with the BIND. So why the BIND is more common in the developing countries? As the developing countries like India, where we don't have proper screening for the neonatal jaundice, majority of the areas may not have a transcutaneous bilirubin meter. And there may be in areas where we cannot have easy availability of the measurement of the total serum bilirubin levels. So the measurement of the jaundice only by the clinical is being done. So that clinical assessment is important, but it may not accurately tell what is the level of the jaundice in the baby. Also, in countries like Asian countries, where we have more chance of the G6PD deficiencies, more amount of RHIS immunization, and more the chance of sepsis, these lead to the more amount of the hyperbilirubinemia and more chance of the BIND. We have seen that the babies who are getting the BIND has predominantly been missed, and there might be some delay in the referrals that can contribute to the development of the BIND. And also in some centers, we might be providing the phototherapy. However, we may not monitoring the flux of the phototherapy. So we're not giving the intensive phototherapy that can lead to inadequate decrease in the bilirubin levels. And as a baby, we think that babies are on the phototherapy. We thought that it will decrease and will not cause any neurological dysfunction. But due to ineffective phototherapy, and we are not able to monitor properly, the bilirubin levels may shoot and can lead to the BIND. And there are certain areas where the healthcare workers are still not aware of these conditions. And we see commonly in our setup that the parents may not consider the jaundice as a very significant disease, and they want to do the conservative management with the traditional ways, thinking that the jaundice level will come down and ultimately present to us with the very high levels of the bilirubin. So these factors is actually contributing to significant amount of BIND in the developing nations. So usually the bilirubin causes neurological injury in the following ways. And these are the factors that actually determine the neurological injury by the bilirubin. So one is a concentration of the serum unconjugated, the free bilirubin levels. Not only this free bilirubin, the amount of the albumin also makes a matter. And when the albumin is present, the capacity of the albumin and the affinity of the albumin to bind with the bilirubin matters. And the presence of acidosis in the form of elevation of hydrogen ions can affect this bilirubin and albumin binding and other factors. And the protective blood-brain barrier may be disrupted or may be normal, but some factors may promote the more amount of transfer of the bilirubin to the brain. And there should be susceptible neurons in the brain, which can lead to the damage by the deposition of the bilirubin. So there are 6 major determinants which determine the neural injury by the bilirubin. So coming to the first determinant, the concentration of the serum unconjugated free bilirubin. So we have seen that many reports and many throughout the history and many research has told that the hyperbilirubinemia associated with the hemolytic jaundice is more associated with BIND compared to the hyperbilirubinemia without hemolytic jaundice. However, just the mere presence of the high bilirubin levels may not alone be significant to cause the bilirubin-induced neurological dysfunction. We might have seen many babies who have very high bilirubin levels around 25, 30. Still, they might not have developed the neurological dysfunction. It suggests that not only the just mere presence of the high bilirubin levels will cause the neurological dysfunction. Also, the amount of the duration these high bilirubin levels are present in the body will determine the neurological dysfunction. In a preterm babies, we see that even the low bilirubin levels may also lead to the kernicterus, because these babies also, along with these high bilirubin levels, maybe like low bilirubin levels, have other associated comorbidities, which includes they might having acidosis, they might having immature blood-brain barrier, sepsis, and they might have more amount of enterohepatic circulations, and they also have associated risk factors in the form of any brain bleeding, IVH, meningitis. All these comorbidities can lead to the increase in the BIND levels when the bilirubin levels may not be that high. And when we ask about whether it is a total bilirubin or is unconjugated bilirubin, that is more important is the unconjugated bilirubin, and it is unbound to the albumin, which is called the free bilirubin, is the more important pathological bilirubin that causes this neurological dysfunction. So in this table, we can see that the babies who are having very high bilirubin has a higher chance of developing the connectors. The babies who have just moderate to mild elevation of the bilirubin have very less chances of having the connectors. But as we have discussed earlier, just presence of the high bilirubin doesn't definitely lead to the connectors, because we can see out of the 11 babies, only 8 babies have developed connectors. And we have seen the rest of the babies, 3 babies, escape from the developing the connectors. As we have told that the free bilirubin that is not bound to the albumin is the most important corroboratory factors for developing the bind. However, it is very difficult to measure the free bilirubin level that is not bound to the albumin. So we use a BMR, that is total bilirubin to the albumin molar ratio, as a surrogate factor for the unbound free bilirubin levels. But studies have done to compare whether the use of a protein total bilirubin or bilirubin albumin molar ratio to determine the phototherapy or determine the exchange transfusion have shown that initially it was a promising result with the using of the BMR, but subsequent studies, especially less than 32 weeks of the gestation, where in the short-term period, they might be showing some differences. However, when compared to the neurological developmental outcomes at 18 to 24 months, the usage of either total bilirubin or bilirubin albumin ratio are not having a significant difference in the neurodevelopmental outcomes in the long term. So still in majority areas, we are using only the total serum bilirubin as a marker for the prediction of the bilirubin-induced neurological dysfunction. So we are having very high bilirubin levels, but our body is being formed in such a way that we have other protective mechanisms to counteract these high bilirubin levels. So one of the things is we have a serum albumin level. So the serum albumin can bind around 1 gram to the 8.5 milligram of bilirubin, and it try to maintain this high levels of the bilirubin in the intravascular space or deposit skin, not allowing to cross the blood-brain barrier. However, the newborns have very less amount of the bilirubin albumin, and also the binding affinity is very less compared to the adult levels, and the adult level is reached only around 5 months of the age. When the albumin levels are low, we can see that normally the bilirubin and the albumin will be formed, and if the bilirubin anion is not bound with the albumin, it can bind with the 2H plus in the normal pH and can result in the formation of the bilirubinic acid. And as I discussed, this bilirubinic acid has a high chance of getting microaggregates and insoluble precipitates and can damage the cell membrane. So in this way, albumin, you always try to prevent the bilirubinic acid formation, and it helps in preventing this bilirubin, high levels of bilirubin to cross the blood-brain barrier. In a newborn, not only the bilirubin level, albumin levels are low, also the affinity between the bilirubin and albumin is also a bit low. And this bilirubin binding capacity of the bin is low per se in the newborn babies compared to the adult, and they are much lower in the sick term and the preterm units. Even though the serum albumin concentration is also lower in these patients who are sick when they are compared to the healthy term counterparts. The bilirubin binding capacity of the albumin will decrease as the pH drops less than 7.4, and as more acidosis is going on, there's a more chance of the formation of the bilirubinic acid, which is the most pathological form of the bilirubin. So not only the bilirubin binding capacity of the bin is low in the preterm and the sick units, there are also certain exogenous and endogenous substances that promote the dissociation of the bilirubin and albumin and promote the more amount of the free bilirubin, can lead to the more amount of the chance of the bind. So there are endogenous anions like the free fatty acids, which compete with the bilirubin for the binding of the albumin and can lead to more amount of free bilirubin. So these fatty acids act as an endogenous anions are released more commonly in the case of the hypothermia, hypoxemia, hypoglycemia, sepsis, and starvation. And when we are giving heparinized blood, and in the case of parenteral nutrition, in all these conditions, the free fatty acids are elevated and they can compete with the bilirubin to bind with the albumin, and this leads to more free bilirubin. And there are certain exogenous anions compared to the albumin, which includes the sulfoxyl, the ampicillin, the ceftriaxone, the ibuprofen, which is the most commonly used drug for the patent actus autism preterm babies. The benzyl alcohol, which acts as a preservative in many of the medications. And there's certain substance in albumin preparation, which actually can compete with the bilirubin binding of the albumin. So in these, so whenever these conditions are present, so there's more chance for the bilirubin induced neurological dysfunction. So that's the reason when we are avoiding the ceftriaxone in the newborn period, we are dealing with other antibiotics in order to prevent this bind. So the concentration of the hydrogen anions is increased, that lead to the acidosis. This acidosis can lead to more neurotoxicity of the bilirubin. It lead to deleterious effects in the form of it affects the level of cellular binding of the bilirubin and can increase the uptake of the bilirubin, and can affect both. Thus, the acidosis can lead to the dissociation of the bilirubin from the albumin, can lead to the formation of bilirubinic acid. Similarly, the babies with asphyxia and they won't be more having acidosis and more amount of the H plus ions. This kind of acidosis can also lead to more amount of the bilirubinic acid formation and the subsequent development of BIND. So here we can see that in the babies who are having the high acidosis, the bilirubin get dislocated from the albumin, it bind with the 2H plus and formation of bilirubinic acid. This bilirubinic acid will bind with the cell surface membrane components, predominantly the phospholipids and the gangliosides and sphingomyelin, and this can lead to the cell membrane damage. And this formation is more pronounced in the babies who are having more amount of hydrogen ions with less pH. The binding increases as the acidosis is worse. So in the case of asphyxia, the chance of the bilirubin neurotoxicity is high because the asphyxia itself, because of the acidosis and development of the endogenous anions like free fatty acids and other anions, can lead to the impaired binding of the bilirubin with the albumin, and there is more amount of the proportion of free bilirubin levels. And the acidosis per se, as we have discussed previously, will lead to the more amount of the development of the bilirubinic acid, which is the most toxic form of the bilirubin. And in the case of asphyxia, we usually see in the blood gas that there will be more amount of the PCO2 hypercarbia, there will be hypoxia, that will lead to the more amount of the blood supplied to the brain in order to provide the oxygen and remove the carbon dioxide to the brain. So that lead to the more amount of the blood flow, more amount of chance of the deposition of the bilirubin in the brain. And the ATP mechanisms are being affected most because of the decreased production of the energy that lead to the decreased expulsion of the bilirubin from the neuronal cells into the extracellular space. Also, in the case of hypoxic ischemia, the damaged neurons are more susceptible to the bilirubin injury. It can act as a synergetic effect on the damage of the neurons. There is also hypoxic ischemic injury related increased amount of the glutamate will be there, and also the free bilirubin will lead to the more amount of the glutamate released from the astrocytes. So both of this lead to more amount of the excitotoxic damage to the neurons in the brain. So in this way, asphyxia has multiple mechanisms through which it can lead to enhancement of the bilirubin neurotoxicity. So usually the blood-brain barrier try to prevent the entry of the bilirubin into the brain. So we have two important mechanisms. So whenever the bilirubin is distant from the albumin and more amount of the unbound free bilirubin present, because of various other factors, the bilirubin levels can go into the brain. However, there are two important mechanisms, transporters. So one is present at the blood-brain barrier on the endothelial surface. This is ABCB1. And the second one is present on the blood cerebrospinal fluid barrier, which is present in the choroidal plexus, that is ABCC1. So usually these transporters will lead to expulsion of the bilirubin from the intracellular space into the extracellular spaces, and then they are transported across the capillary endothelial cells to the blood. In this way, they try to prevent the deposition of the bilirubin in the neurons and other part of the brain. However, these transporters may be affected either genetically, leading to the decrease in the efficacy, or maybe because of any hypoxia or any other hypoglycemia or any asphyxia lead to decrease in the ATP production and can lead to impairment of this function that can lead to the more amount of the bilirubin get deposited in the brain, can lead to the damage of the brain. So the bilirubin transport into the brain can be happen through intact blood-brain barrier and can also happen to the disrupted blood-brain barrier. So when in the case of intact blood-brain barrier, this free bilirubin, increased levels of the free bilirubin level can be actively transported or passively transported from the blood intravascular space into the brain and can overwhelm the exporters, ABCC1 and ABCC2, which are the transporters which lead to the efflux of the bilirubin from the brain to the extravascular spaces. So very high levels may not be sufficient enough to be exported to the transporter. Also, as we discussed, increase in cerebral blood flow can happen because of any hypercarbia, seizures, hypoglycemia, and hypoxia, where there's more amount of the blood flow can go into the brain, and this can lead to transport of the bilirubin levels, even though the blood-brain barrier is intact. And when the blood-brain barrier is disrupted, there's no chance for the deposition of the bilirubin in the brain. So when you use hyperosmolar agents like sodium bicarbonate, hypertonic glucose, of introducing exchange transfusions where you use more amount of the concentrated blood, that can lead to the hyperosmolar can damage the blood-brain barrier, that can lead to the more amount of bilirubin enter into the brain. And in case of the hypercarbia with acidosis, as I said, there is more amount of cerebral blood flow that can happen to the brain that can itself disturb the blood-brain barrier and can lead to the entry of the bilirubin into the brain. And asphyxia through the multiple mechanisms we discussed, increase in the blood flow, we can damage the transporters, can damage the endothelium, all these ways. In acidosis, all this can lead to the increased amount of the transport of the blood-brain barrier. The acidosis per se can lead to more amount of bilirubinic acid and can lead to the transport and can damage the endothelial barrier and can lead to the more amount of bilirubin entry. And we can see that meningitis where there is a vasculitis, where there is again damage of the endothelium can lead to the transport. And any abrupt increase in arterial blood pressures or abrupt increase in venous pressure can damage the endothelium, can break down the blood-brain barrier, can lead to more amount of the deposition of the bilirubin in the brain. So in this way, the blood-brain barrier can be bypass whether it is intact or whether because of some other mechanism there is a disruption in the blood-brain barrier, the bilirubin can enter into the brain and get deposited in the different parts of the brain. Not only the so a majority of the bilirubin will enter into the brain, but there should be susceptible neuronal cells which will be affected by the bilirubin. So for the studies, we have found that there's a distinctive regional topography of the brain injury that happens in the case of the Kernicterus. The predominant involvement is the neurons because they have a high amount of the receptors for these things and a receptor for the deposition of the bilirubinic acids. Not only the neurons, there can be involvement of the astrocytes and microglial cells can also be involved, but may not be that significantly affected in the case of the neurons. Whenever there is a concomitant injury to the neurons in the form of asphyxia, there will be more chance for the bilirubin encephalopathy, and any additive effects will be happening if the baby is already had any other neuronal damage, things like hypoglycemia, any metabolic derangement, or already there's intracranial hemorrhage and infection, and in trauma or expert toxic agents. So traditionally, we know that the most common areas that are involved in the case of the bilirubin-induced neural dysfunction is globus pallidum. However, there are other variable areas that can be included. One is the cerebellum, hippocampus, subthalamic nuclear bodies, as well as other certain cranial nerves that can involve oculomotor nerve, that can involve your vestibular cochlear nucleus, and can also involve the facial nerve nucleus. But the most common areas of involvement is the globus pallidum, which can identify in the case of neuromacy. There are multiple mechanisms through which the bilirubin will actually lead to the damage of the brain. One, it can affect the glucose utilization. It impairs the oxidative phosphorylation, so it impairs the development of the ATP. And it can affect the anabolism by affecting the synthesis of DNA protein. It affects many enzyme activity. It also affects the protein phosphorylation, neurotransmitter synthesis. As the energy is depleted, it affects the ion transport and the synaptic transmission. There's more amount of the excitatory amino acid homeostasis. There is more amount of the cytosolic calcium concentration. And there is more amount of the free radical injury can happen. And there's more amount of inflammatory homeostasis and apoptosis, and the survival balance will be affected, more prone for the apoptosis. So normal as I found that whenever the bilirubin can get deposited different parts of the brain, so the usual protection factor is the ABCC-B1 ABCC will lead to the export of the bilirubin from the intracellular space to the extracellular space. And we have the cytochrome P450 and the bilirubin oxidase, which can lead to the production of the boxes, that is the bilirubin oxidation products. However, when this production is not sufficient enough to cater the high amount of the bilirubin level, it can lead to the damage. So the neurons, the damage can happen because of decreased energy, decreased oxidative consumption, that lead to the affecting of the transporters. There's more amount of the calcium, more amount of caspases that can lead to the apoptosis, and it can also affect the arborization of the dendrites and the axons. In the astrocytes, there will be more amount of pro-inflammatory cytokines, and it can also, the damage can lead to more release of the glutamate release, which further activate on the neurons and can lead to the exudative damage, and the pro-inflammatory cytokines can also lead to the apoptosis. In the microglia also, there will be more amount of pro-inflammatory cytokines, then lead to the more amount of metalloproteins 219, which lead to the more amount of the phagocytic activity. In oligodendrocytes, there will be affecting the mitochondrial function. There is more amount of reactive oxygen species. Similar to the neurons, there can be more amount of caspase 3 activation and more amount of apoptosis. Oligodendrocytes, one of the most important damage the bilirubin causes in oligodendrocytes is decrease in the myelin synthesis that can affect the further development of the brain, of the white matter. So whenever there is a damage to the astrocytes, as we can see that it inhibits the uptake of the glutamate, more amount of the glutamate will be present in the outside the astrocytes. The bilirubin itself damages the cell membrane of the neurons. It affects the mitochondrial function. There is more amount of cytochrome C release and pro-apoptotic mechanism lead to apoptosis. The mitochondrial lead to the decreased energy production, and there is more amount of the calcium release from the endocrine reticulum. It can have the free radicals generation and can lead to the necrosis. Also, by the action of the glutamate, the NMDA receptors can be opened up and the calcium can enter and itself can again activate the free radicals and lead to the necrosis in the neurons. So, after understanding this, we can have these novel interventions which can be used in the future after adequate research, where the NMDA receptor blockers can be used, which are include the memantamine, dextromethorphan, magnesium, and the MK801. We can use antioxidant therapy to decrease the antioxidation. We can use the anti-inflammatory and antimicrobial agents to inhibit the phagocytic like minocycline, and we can identify and use anti-apoptotic agents, or we can use all these interventions in a combination in order to prevent the bilirubin-mediated neurotoxicity. So the neuropathology of the bind includes two essential factors. First, there should be a bilirubin staining of the specific nuclear groups that we have discussed earlier, and that lead to the various mechanisms that will ultimately lead to the necrosis of the neurons. So these are the three important neuropathological states. One, there can be an acute bilirubin encephalopathy or connectors of a full-term or a premature infant, which have a very marked hyperbilirubinemia. And the second thing is acute bilirubin encephalopathy or connectors of the premature infant without marked hyperbilirubinemia. This is called low bilirubin connectors. And the next thing is secondary bilirubin staining of the brain nuclei in the case of premature infant, even though there is no significant hyperbilirubinemia. However, this bilirubin staining is just staining the brain nuclei and is not causing any neuronal damage in this kind of the premature babies. So staining and necrosis of the neurons predominantly involve the basal ganglia, especially the globus pallidum, hippocampal cortex, subthalamic nucleus, cerebellum. And after that, there will be necrosis, and finally, there is the gliosis of these areas in the cervix. The globus pallidum is affected because there is high baseline level of neural activity, which is susceptible to any energy failure. And there is high neuronal glutamate receptor density, so that whenever the more amount of the glutamate is present in extra neural space, will act on the glutamate receptors and lead to the exudative neural injury. The hippocampus is the most sensitive brain region and followed by the inferior colliculus. Usually the cerebral cortex and superior colliculus are generally spared, that's why the consciousness and this is usually present intact in these babies, and the seizures are less common in these babies. The kind of neuropathology in the case of the bilirubin encephalopathy is different in case of a full-term and the premature infants. Compared to the full-term babies, the premature babies, hypothalamus is usually spared. Compared to the full-term babies, the premature babies have the involvement of the Purkinje cells, where the full-term babies doesn't have the involvement of the Purkinje cells. The rest of the globus pallidum, subthalamic nuclei, hippocampus, substantia nigra, cranial nerves, reticular formation of brainstem, cerebellum, dentate nucleus, and the anterior spinal cells are equally affected in both the preterm and the term babies. Only the preterm babies that doesn't involvement of the hypothalamus, and compared to term babies, they have the involvement of the Purkinje cells, is seen in the case of preterm babies. Also, the topography is different between the connectors and the hypoxia encephalopathy. So in the case of the connectors, as we discussed, the cerebral cortex and the periventricular white matter is spared, which is the most common involved in the case of hypoxia encephalopathy. The basal ganglia are involved, but the areas of basal ganglia are different. Caudate and putamen are involved in the hypoxic ischemic encephalopathy, whereas globus pallidum is involved in the connectors. Even the areas in the hippocampus are different, and the cochlear nucleus and dental nucleus are involved in the case of the connectors, and they're not involved in the case of the HI babies. So, how this bilirubin encephalopathy present? So they can present as an acute bilirubin encephalopathy in the newborn period immediately because of high bilirubin levels and damage, or they can have a sequel of these high bilirubin levels later in the neonatal period or in the infancy. So the acute bilirubin encephalopathy connectors is a term usually seen when the babies have a high bilirubin and little symptoms in the immediate and neonatal period. So the most affected babies usually have a definite neurological symptoms. However, around 15% of the babies can have acute bilirubin encephalopathy but may not have any definite neuronal signs. And we miss these kind of the babies and later they present with the connectors, chronic bilirubin encephalopathy. There can be certain subtle signs which are equivocal neurologicals in 20 to 30 babies. However, around 55 to 65% of the babies have a definite neurological signs where we can identify this acute bilirubin encephalopathy. The major neurological features includes the involvement of level of consciousness, the tone and the movement, the brainstem function, especially that related to the feeding and crying. So usually in the case of acute bilirubin encephalopathy, there will be three phases. In the first initial phases, there is a slight stupor where the baby is more lethargic and sleepy. There will be mild hypotonia. There will be poor sucking with a slightly happy children. In the intermediate phase, the slight stupor goes to the moderate stupor with irritability. The tone will be variable. Sometimes there will be retrocolis and opisthotonus. The feeding will be affected significantly. There is definitely high pitch. In the advanced phase, from the initial phase, the slight stupor, moderate stupor, and then go to the deep stupor and coma. And the baby's tone will become so pronounced and can pronounce retrocolis and opisthotonus. And there will be very minimal and no feeding, and the cry will move from the high pitch cry to the shrill cry. So here we can see the picture of the babies with bilirubin encephalopathy, where we can see the prominent retrocolis and opisthotonus posture. So this is a face of the baby with the bilirubin encephalopathy, where you can see that there is upward gaze palsy with retract eyelids. There is a sunsetting sign, and we can see this anxious or stunning look. This is called as a connected faces. So in the case of the preterm neonates, the acute bilirubin encephalopathy may not be happening at very low, may be happening at very low levels. So these babies might have a lower TSBs compared to the term babies, where the bilirubin encephalopathy can still happen. So the signs are very subtle, and these are the most commonly these preterm babies anyway will be exhibiting because of their other comorbidities. So they can present with lethargy, decreased activity, apnea, tachycardia, hypertension, irritability, seizures, stupors, hypotonia, oculogaric movements, and hyponatremia. So one of the most thing is frequent apneas who require bag and mask ventilation is also in one of the sign of the acute bilirubin encephalopathy in preterm units. So in these preterm units, as these signs are seen in majority of the other comorbidities of the preterm babies, the high index of suspicion is needed in order to identify this acute bilirubin encephalopathy in the unit. And many babies we might miss because these signs may not be attributed to the ABE. Then coming to chronic post-kernicteric bilirubin encephalopathy, which we previously called as a kernicterus, is a classically has extrapyramidal abnormalities in the form of acidosis. The gaze abnormalities are upward gaze palsies, and there is auditory disturbances, especially the sensory and hearing loss, with relatively sparing of the intellectual. So coming to the extrapyramidal movements, there will be motor phenomenon which will be usually present in every case, but the severity may be vary. Principally, it involves acidosis, where the upper limbs are more affected than lower limbs, and there is an affection of the swallowing, phonation, and the facial movement. And babies usually have intermittent dystonic posturing. Even though the acidosis principally is the most common presentation of this kind of motor phenomenon, there can be other extrapyramidal symptoms in the form of chorea, valismus, and tremor can happen in very few babies. The case abnormalities occurs in most patients, and usually the vertical gaze palsy will be there, and the babies have a characteristic connectress faces, as we have discussed previously. The auditory abnormalities are also more commonly seen in the case of the chronic bilirubin encephalopathy. Usually the high frequency loss are there, which are usually bilateral. We have a special name for this auditory abnormality. We call it auditory neuropathy or auditory synchrony, which happens only in a babies with having a bilirubin induced injury. So here we have there is an absent or abnormal BERA. However, the normal tests of the inner ear function are there. The otoacoustic emissions are normal because the inner ear function is normal. The predominantly affecting the pathway is your neurons, is the nerve beyond the inner ear cells. So we have a normal otoacoustic emissions and we have an abnormal BERA. So this is called as auditory neuropathy, auditory dysynchrony, where we have a normal OAE, however an abnormal BERA. Sometimes these babies may not have actually hearing loss, but they have an affection in processing the sound. So may not have any loss of the decibels, but when they are not able to process the sound normally and compared to the babies who doesn't have a bind. The intellectual defects happen only in very minor babies. The movement disorders and auditory problems actually may mask this paired function. Sometimes the chronic bilirubin encephalopathy can happen without marked neonatal hyperbilirubinemia because it can involve a less marked neonatal hyperbilirubinemia, but will happen in the shorter duration of the hyperbilirubinemia. This usually happens in the premature babies and babies who are having any other risk factors where the where may not a significant hyperbilirubinemia and not a prolonged duration can still lead to the chronic bilirubin encephalopathy. However, this kind of the encephalopathy may not follow the full classical picture of the postclinic type. As we have discussed, premature infants without marked hyperbilirubinemia can have this kind of the bilirubin encephalopathy. However, the spectrum of the neurological defects is different compared to the term babies who doesn't have a significant hyperbilirubinemia. The neurological sequence in the term babies without marked hyperbilirubinemia usually results in early delay in the motor development. However, the neurological development or cognition at the 4 to 13 years are normal. The neurological sequence in the premature infants without marked hyperbilirubinemia can have several syndromes of the chronic bilirubin encephalopathy. So we have seen predominantly two forms. One is a chronic bilirubin encephalopathy plus classical post-clinic, which usually will be less seen in the premature babies, either with both marked and without marked hyperbilirubinemia. However, in the case of a without marked neonatal hyperbilirubinemia, there can be partial forms which have only predominantly auditory involvement because of the more sensitivity of the auditory nuclei of the brainstem in the premature infants. Or they can have a mixed auditory and the motor form, and rarely they can have only the predominantly motor form. So usually they have a predominantly auditory form and more common is the partial forms. So the auditory dysfunction in preterm babies is more common in the less than 1.5 kgs with a high level of bilirubin around 14 milligram per deciliter. They have a high chance of the high risk of the deafness where they can have auditory syndrome. Also, the longer duration of the bilirubin and associated risk factors like acidotic episodes or sepsis can lead to the increased risk. In a full-term infants, the total bilirubin level that lead to the ototoxicity are less specific. However, anything more than 20 milligram per deciliter usually can lead to ototoxicity. So we should be more vigilant in these babies. And there is selective injury occurs in the brainstem auditory nuclei, possibly the auditory nerve and the spiral ganglion. So that is why we have a normal otoacoustic emissions with an abnormal bear. Coming to diagnosis, one thing is we have to measure serum bilirubin measurements, and one is a beta, and third is an MRI. So the bilirubin measurements should be done in any suspicion of the bind. However, it just help us to identify the babies who are on the high risk of the developing the brain injury. As we discussed, compared to the not only the high levels of bilirubin, we need the amount of the more free bilirubin levels and the ability of the albumin to affinity and the albumin capacity to bind with the bilirubin is also important. However, we cannot use these measurements clinically, so we are using the total serum bilirubin levels as a thing who will help us in identifying the risk babies who are going for the chance for the bilirubin neurological dysfunction. And coming to the brainstem, so we can identify the we can detect the bilirubin neurotoxicity by using the brainstem evoked response. So these observations are most consistently seen in the babies who are having the bind. So we can see there is an increase in the latency for the wave 1 and the conduction times have been increased between the 1 and 3 and the wave 5. And luckily we have seen that the babies who are having these abnormalities and after the treatment, when the bilirubin levels will come down, the responses will become normal once we have reversed the primary condition and we have reversed the bilirubin levels to the normal. So this is a data where we can see there are different waves. So the latency for the wave 1 and the progression from the 1 to 3 waves and the 1 to 5 waves visually measured, and any abnormalities in these things is the earliest diagnosis that we can have in babies of bind. And after the treatment, they usually reverse to the normal. Next is neuroimaging. So MRI is a better scan to identify the bilirubin induced neurological dysfunction. So the most commonly affected is globus pallidum. The subthalamic nucleus can be affected or not, and there can be involvement of other areas. However, the involvement of the globus pallidum is the pathognomic of the connectors. Sometimes the babies can have a normal MRI and it may not exclude the diagnosis of the bilirubin induced neurological dysfunction. If any other rare areas like a caudate, putamen, thalamus, cortex, and the periventricular white matter are involved, then the chances of having the bilirubin induced neurological dysfunction is much less, and there might be the cause for the neurological dysfunction should be other factors rather than the connectors. When you do neuroimaging, so if you do the MRI in the initial days and weeks after the bilirubin encephalopathy, we have seen the changes in the T1. So in the T1, we have a more increase in signal intensities in the globus pallidum and subthalamic nucleus. However, the T2 signal in the early phase is mostly unremarkable, or the cannabinoidal hyperintensities can be noted. However, without any significant history, very presence of the high T1 signal is non-specific for a bilirubin-induced neural dysfunction, because normal maturation process can also lead sometimes to the high T1 signals in these regions. Early indication of conductors is done by the high signal in the subthalamic nuclei in the globus pallidum in the babies who are having any high risk factors with high bilirubin levels for the bilirubin-induced neurological dysfunction. So this MRI of the babies, we can see that this is a T2 image. This is a T1 image where the CSF is appearing black. So we can see that this is a globus pallidum and subthalamic nucleus are the hyperintensities. And in the case of a T2 weighted images, where your CSF is white, usually we may not have this hyperintensity globus pallidum, but we can see that slight hyperintensity is still present in the T2. So this can happen in the T2 image in the immediate period. However, the most characteristic findings will happen in the T1 weighted images. And DW weighted images, we don't find any diffusion, which usually we'll see in the case of the babies with hypoxic ischemic encephalopathy. So it's a baby who around 6 months old. So where we know that the T2 images are more prominent than the T1. So where we can see this globus pallidum hyperintensities are there, and even the subthalamic nucleus and the substantia nigra is also being hyperintense in these areas. In the T1 images, we can still see that the part of the globus pallidum is mildly hyperintense. So after the acute bilirubin encephalopathy for chronic bilirubin encephalopathy, the T2 weighted MRI will give a better idea compared to the T1 weighted MRI. In the initial acute bilirubin encephalopathy, the T1 weighted MRI is better than the T2 weighted MRI. So we usually follow the BIND scores in order to assess the bilirubin neurological dysfunction. So it consists of three important parameters. One is the mental status, the muscle tone, and the cry pattern. So we give the scoring of 0, 1, 2, 3. 0 is usually normal, and the 3 is more advanced dysfunction is happening in the baby. So mental status, the baby will be normal, sleepy, lethargic, semi-coma, apnea, and unable to feed, and seizures and coma are there. The muscle tone, the baby will be normal, or there may be mild hypotonia, and then it can lead to the moderate to hypertonia, and there may be arching of the neck and the trunk on the stimulation, and then going to the advanced stage, the baby has a persistent colis and opistotonics with the bicycling or twitching of the hands and feet. The cry pattern is normal in the initial phase, and in the case of subtle, there will be high pitch cry, and then will be shrill cry, and finally there will be inconsolable cry, or baby is very weak or absent cry because of inconsolability. So nowadays the total score ranges from 0 when there is no bind. The maximum score is around 9. The score 1 to 3 is called as mild bilirubin encephalopathy, where there are subtle signs, and this usually get reversible with the treatment when you control the bilirubin levels. The 4 to 6 is moderate acute bilirubin encephalopathy, and where the chances of the neurological function are still reversible with the early, urgent, and the prompt bilirubin reduction strategies like intensive phototherapy and extended transfusion. And the score 7 to 9 is advanced acute bilirubin encephalopathy, where we require urgent, prompt, and individualized interventions are needed, because by doing this, we can prevent the further brain damage. We can minimize the sequelae of the already damaged brain, and sometimes, if you are lucky enough, we can reverse the damage that has already happened by removing the bilirubin from the body. And then comes the term of modified bind. So along with this mental status, cry, and the tone, so the modified bind score has a gaze component. So when the normal gaze, it is 0. And when there's a sun setting or paralysis of the upper gaze, score is 3. It doesn't have a scores of 1 and 2. It has only scores of 0 when it's normal gaze, and where's the 3 when there's abnormal gaze in the form of sun setting or paralysis of the upper gaze. It is a more comprehensive score than better discrimination degree of the simple bind. The maximum score is 12 in compared to the routine bind, where the maximum score is 9. So the score 1 to 4 here is indicator of mild ABE. In the case of routine bind, it is 1 to 3. The score 5 to 6 is indicator of moderate ABE. In the case of normal bind, it is 4 to 6. And the more than score indicates severe or very severe. So the modified bind has better discriminative of the various severity of the bind compared to the routine bind. Coming to the treatment, so we need to address the neurodevelopmental sequence that happened because of the damage to the brain. We need to provide physical, occupational, speech, and audiological therapies. We can do certain medication that decrease this morbidities, and we need to identify the complications that, especially as per the daily activities like feeding and nutrition. We need to address the gastric reflexes, sleep disturbances. We need to decrease the tonicity and prevent or treat the muscle cramps. So the auditory defects can affect the speech. So the auditory is dysynchronia, auditory neuropathy. We can use acute speech where you can have speech, lip reading, and the hand signals can help in better language and the literacy in the babies. And many children who are fitted with the conventional amplification can have a reasonable speech and language abilities, but we should not do over amplification as it can lead to the permanent damage to the cochlea. For the motor deficits, the physical occupational therapies are very helpful. As intelligence is normal, we can have a better cooperation from the babies and the patients. And we can use the reversible walkers has been used with much helpful in this kind of the patients. The benzodiazepines such as diazepam, baclofen are beneficial in decreasing the tone and preventing this cramps. The tendon lengthening are usually not advisable in these babies who have hypertonia with contractures. We can use the botulinum toxins which can be used and with the adequate physiotherapy and occupational therapy, the babies can have a better outcomes. Whenever there's severe dystonia affecting the sleep and other affecting the daily activities, we can use the intrathecal baclofen pumps can also be given. TBS deep brain stimulation has been useful for the patients who have been connectors, which are shown to the positive outcomes in these kind of babies. As we've seen, the teeth enamel is affected in case of a chronic connectors. The dental enamel is usually affected in these babies. And initially, the deciduous teeth are affected, but the permanent teeth are not affected as they might have not erupted at the point of the time. So the enamel may chip and flakes, and many children may end up with having the capping of the teeth. The good dental hair helps with managing these deciduous teeth, and finally the normal permanent teeth will erupt, and this after that this connectors will not have any effect on this permanent teeth. The babies who have been having difficulties in feeding and who are malnourished, we can use the gastrotomy tubes that improve the weight gain of the babies. And if they have a significant gastric reflux, even after the medications, anti-reflux medications, we can think of using nascent fundoplications so that the babies have a decreased GR and better weight gain. The CS are very less likely because of the cortex involvement is unlikely in the case of the connectors. So one majority of the times we can get confused with the abnormal movement, dystonic movements as the seizures. So we require a video EEG for the diagnosis, and any seizures are there we need to treat. Because these babies have hypertonias and very painful spasms, they usually affect the sleep. And even after the babies get up from the sleep, and it's very difficult for them to go back to the sleep. So the sleep disorders is maybe one of the most problematic in these babies. And so the management is not a single person management. We need a team where the pediatrician or the neonatologist will, along with the audiologist who take care of the hearing, pediatric ophthalmologist who will take care of the vision and the sunsetting signs, and the clinical psychologist will help in promoting the boosting the baby's moral and promoting the well-being of the baby. And we should have a social worker who will help the families, and we should have a nurse who help them in the nursing the baby and doing various other helping for the parents. The developmental therapeutics will be there in order to identify the developmental delays, and there should be other specialists like we can have this pediatric surgeons and we can orthopedics so that a neurologist where we can overall form a team and can help the babies who are having the bilirubin induced neurological dysfunction either acute or chronic states. My take-home points are the early detection of the bind and the monitoring of the bind scores can prevent the irreversible neurological damage. Whenever the babies are having any high bilirubin level, one, we should monitor the bind scores and we should act as soon as the bind scores are increasing. And the babies who are having even the bind score of 1 should be treated and more aggressively. 1 to 3 mild bilirubin in neurological dysfunction doesn't mean that the babies are not having any risk for the brain injury, but the risk are a bit low. So we should monitor the bind scores in all the babies who are having the very high bilirubin levels, and we should act accordingly the levels. Just measurement of the serum bilirubin levels will not give the prediction for the bind, because I've seen that in the case of preterm babies and babies who are having other risk factors like asphyxia, like sepsis, even the very high bilirubin levels may not be needed to have the bilirubin induced neurological dysfunction. One should think of these risk factors and then consider the bilirubin levels in prediction of the bind. Auditory dysfunction may be the only manifestation of the bilirubin toxicity initially. So we can use the beta to screen these babies if you have any suspicion of any neurological dysfunction. And if you find any abnormalities in the beta, we can go with the treatment so that we can see that the auditory dysfunction can also be reversible after the appropriate treatment. And as we discussed, prevention is always better than the cure. We need to educate the parents and the caregivers for the treatment of the aggressive treatment of the jaundice, and do not take the jaundice in a lighter way, and don't go for any traditional methods for the improving the jaundice in the newborn babies. And we should educate them in such a way that they should approach to the healthcare providers as early as they identify the jaundice in the babies, and they should follow the appropriate treatment guidelines advised by the healthcare providers, so that this kind of a preventable neurological dysfunction should be avoided in the babies. So with this, I conclude my presentation. Thank you. And